What's good for the heart in general is good for the brain.
Welcome back to the Exam Room Nutrition Podcast, your guide to giving better nutrition advice. I'm your host, Colleen Sloan. I'm a PA, registered dietitian, and I'm really excited to have back on the show Josh Wageman. So not only is he a clinical lipid specialist, he's a PA. He also has his PhD in which he studied cholesterol disturbance in Alzheimer's disease. You might remember him from prior episodes. We've done 2 different episodes unpacking cholesterol and diet. But I'm really excited to talk to Josh today because we are unpacking how cholesterol impacts Alzheimer's disease. So Josh, thank you so much for being back on the show. Welcome back.
Thanks for having me. We had so much fun the first several times that we just had to do it again.
And you are right. Actually, your 2 episodes on cholesterol and diet were actually my top listened episodes. So congratulations. People love hearing about cholesterol. And so today we are going to unpack brain health. And so we usually think about cholesterol as like, quote, bad for the heart and the cardiovascular system, but the brain is actually very cholesterol rich. And so can you walk us through like what the role of cholesterol is in brain structure and function?
Yeah, and we have to remember that cholesterol is not bad. Every nucleated cell in your body synthesizes its own cholesterol because a lack of cholesterol is incompatible with life. You cannot have atherosclerosis without a cholesterol-laden perpetrator in the arterial wall in the wrong place at the wrong time, and then the maladaptive immune response that ensues kicks off the cascade that results in plaque formation and subsequent clinical events. And so there's a sweet spot. Like most things in biology, it would be nice if it was good or bad. We like things to be binary, but it depends. And so to your point, 20 to 25% of your total body cholesterol is actually in the brain. However, unlike below the brain, where the half-life of lipoproteins is several days, the half-life of cholesterol is 6 months to 5 years. And so the cholesterol in the brain is located in 2 distinct pools. There's a large portion that is in myelin sheaths, and then the other pool is in the plasma membranes of both astrocytes and neurons. And so when we have cholesterol synthesis occurring in the brain, it's really highest, the rate, early in life. And so in the perinatal period through adolescence, that's where the bulk of cholesterol synthesis is occurring. However, in the adult brain, this continues to occur across the lifespan. Now, there are some real big differences, and this is why I had to do a PhD in this, because below the brain, lipids are pretty complicated. But in the brain, it's a whole nother trip. And so below the brain, the primary lipid transportation vehicles are the APOB containing lipoproteins. And so these are the mailmen, as I call them. And the role of these mailmen below the brain is to deliver triglycerides, phospholipids, a few fat-soluble vitamins to target tissues, and then go home to the liver at the end of the day. And these would be like our VLDL, IDL, LDL particles. The HDL particles are more like the police force, but this is where we're talking about below the brain. However, in the brain, there are no ApoB particles, at least there shouldn't be. And so in the brain, the primary mailman, so to speak, is an ApoE containing HDL-like particle. And there's so many hyphens in that sentence I just said that you're like, wow, I don't even know if I want to be this guy's friend anymore. And so really it's an HDL-like particle because it's in the same density range as an HDL particle, and yet its function is far different than what we're seeing below the brain. And so this is already getting fairly complicated, but we'll unpack these things and we'll simplify it at least a little bit. But in general, in the brain, what's supposed to happen is the astrocyte, which it's like a star-shaped cell, and this is called a glial cell. And glial cells are support cells for the neuron because most of our cells in the brain are dedicated to supporting the neuron because the neuron's running the show. And so the astrocyte actually produces the cholesterol. And then that cholesterol is exported into one of these ApoE particles. And then what's supposed to happen is this ApoE mailman then goes and delivers the cholesterol to the neuron because the neuron needs cholesterol, especially in a component called the lipid rafts. And these are cholesterol-rich domains in which neurotransmission can take place. And you will not have adequate synaptic function in the neuron unless you have adequate cholesterol. Conversely, if there's too much cholesterol, then that can lead to issues as well. And actually, beta secretase activity that stimulates the production of amyloid beta, which some people have heard of as far as an abnormal protein aggregate in Alzheimer's, it occurs when there's too much cholesterol. So there's always a sweet spot. So this astrocyte makes cholesterol, gives it to the ApoE particle, and that is supposed to be delivered to the neuron because it's very, very energetically expensive to make cholesterol. Cholesterol requires 36 ATP to make, and the neuron's got better stuff to do, right? And so if the neuron can get the cholesterol from the HDL-like particle that contains ApoE, then it can carry on and do all the things that the neuron does to run the show. However, as we'll talk about, there are some abnormalities here that can occur, and we'll further unpack that as we go.
Super complicated. And you always talk about how you love to nerd out on this stuff. And you're so right. Like brain and cholesterol in the brain is so complicated. But that was a really helpful breakdown of kind of what's going on in the brain. And so I would love for you to give us big picture. How is cardiovascular health and cognitive function connected? And I'm sort of thinking, just because someone has elevated LDL and maybe is at risk for cardiovascular disease, does this also impact their cognitive function down the road?
Yeah. And so this will actually take us back to real life, which is nice because that first little part was a deluge. And so if you're still with us, what's good for the heart in general is good for the brain. Okay, this is refreshing. So here are the things that we know are associated with Alzheimer's disease that are not also good for the heart. So midlife obesity. Nobody's New Year's resolution is to be more obese this year. And that carries a 4-fold risk of Alzheimer's disease. Okay. Diabetes, 56% increased risk of Alzheimer's disease. And one of the earliest signs that we see in people who go on to develop Alzheimer's disease, and even this is before mild cognitive impairment, is glucose hypometabolism. Glucose is a precious fuel for the brain. And yes, the brain can utilize ketones. It can utilize glucose-derived lactate. But it really, really needs to utilize glucose efficiently across the lifespan. Also, there is an over 2-fold increase in risk of Alzheimer's disease for people who have high insulin levels. And if you read my book, chapter 1 is Control Your Insulin, Control Your Life. Additionally, coronary disease. People who have coronary disease in midlife have a 29% increased risk of Alzheimer's disease. Heart disease is bad. Okay, we can vibe with this, right? Diabetes is bad. Heart disease is bad. And then those with the highest CAC scores, and remember, got plaque, get a CAC. CAC is a coronary artery calcium score, and that is evidence of a break-in by one of these cholesterol-laden perpetrators. Those with the highest CAC scores in the MESA consortium also had the highest incidence of dementia. Conversely, those with the highest cardiorespiratory fitness have the lowest incidence of dementia. And then additionally, exercise itself is associated with a 45% decrease in Alzheimer's disease. So there are studies that show from the UK Biobank, for instance, that elevated ApoB in midlife is associated with Alzheimer's disease. And we know that ApoB is a particle measurement because every one of these ApoB-containing lipoproteins is potentially a criminal that can break in to your arterial abode. However, it's a little more complicated than that when it comes to lipids, and there's a sweet spot. And so that's what we'll further unpack when we talk a little bit more about ApoE and why ApoE is a risk factor, a genetic risk factor for development of Alzheimer's disease beyond what we've already discussed.
Yeah, let's get into that because as you just said that with ApoB being a particle, what did you say? What is it?
It's a particle measurement.
Measurement. Is ApoE also a particle measurement? And if not, unpack that gene and its relation to lipids in the brain for me a little bit.
Yeah. So ApoE below the brain is actually a component of most HDL particles and then also some VLDL particles. It's rarely on LDL particles. And that's why LDL particles below the brain have a longer plasma residence time. So the half-life of LDL particles is 2 to 3 days. And that's why a lot of people tend to be scared of the LDL particles because if they're loitering longer, there is more likelihood that they might break in if they haven't adequately gone home to the liver at the end of the day. And so ApoE below the brain, E for easy access, if a particle has ApoE on that, it tends to be cleared more readily. However, in the brain, ApoE is that primary transport lipoprotein. And so when we check an ApoE on somebody, it's not the level of ApoE. If you have a research lab, you can check ApoE levels, but that doesn't necessarily correlate with what's going on in the brain. What we're talking about when we test for ApoE is a one-time test for your ApoE genotype. So the ApoE gene is on chromosome 19, and you inherit one copy from each parent, either ApoE2, ApoE3, or ApoE4. And so most people, 75% of people have 2 copies of ApoE3. So ApoE3, 3. That's normal. But ApoE4, we're going to ignore ApoE2 for right now. ApoE4 is actually the, quote, Alzheimer's gene. Now, this doesn't mean you're going to get Alzheimer's, but if you have one copy of ApoE4, It just means you have less margin for error when it comes to the things that are necessary for preventing cognitive decline across the lifespan. My wife has one copy of ApoE4. And so if you have one copy of ApoE4, you have maybe a 3 to 4-fold increased risk of Alzheimer's down the line. If you have two copies of ApoE4, and this is only about 2% of people, then you have maybe an 8 to 12-fold risk of Alzheimer's down the line. And this has gained popularity because Chris Hemsworth, right? And the dude, I mean, literally he played Thor. So I call it ApoE Thor. He has two copies of ApoE4. And the dude, I mean, he literally descended from Mount Olympus, but this guy, just all things being equal, has a little bit higher risk of Alzheimer's disease than somebody who has two copies of ApoE3. Now, I don't actually think he's going to get Alzheimer's because he knows this and he's taking the appropriate measures across the lifespan, and it's not a deterministic gene. I think I heard Kellyanne Yotis, who's a brilliant preventive neurologist, one time say that your genes are not your destiny, and that's totally true. And so I think that, hey, it's good to know if you have less margin for error, and then you can be aggressive and take matters into your own hands. And there's a lot of exciting research down the line as well. But the reason why this ApoE4 is problematic is because, like I said before, the normal process of cholesterol transport in the brain is the ApoE particle delivers the cholesterol from the astrocyte to the neuron. But ApoE4 particles, they're like easily distractible. They're like easily distractible members of a medical office or a business, and their job is to deliver the memo to the CEO or deliver the prior authorization to the physician so they can sign it. And so the ApoE4 particle, though, they get distracted. And so instead of delivering the cholesterol to the neuron, they get lost along the way. And they're like, oh, what's this? And then they leave cholesterol messes in places where they don't belong. Well, what happens is when cholesterol is in the wrong place at the wrong time, this elicits a pro-inflammatory response. And it annoys the other members of your brain office. And so the microglia. And microglia are kind of like the macrophages or the immune cells in the brain. They're like, what's this cholesterol here? What's this mess here? And then they elicit an inflammatory response to the cholesterol that is not where it's supposed to be. Additionally, neurons can synthesize their own cholesterol and they can synthesize their own ApoE. But when a neuron is synthesizing ApoE, that's a sign of a stressed neuron. So the physician or the executive can try to do the job that the ApoE particle is not doing, but that's a recipe for burnout. And so that's why the three big hallmark disturbances we see in people with Alzheimer's disease are decreased cholesterol transport, decreased ability to eliminate cholesterol where it doesn't belong, and then decreased cholesterol synthesis. And so what happens is when everything's going wrong, then it negatively feeds back on cholesterol synthetic enzymes. And that's why we see actually decreased cholesterol synthesis as well. And this leads to a real big problem, and everything's going wrong when that adequate delivery system is not in place. And so that's a little bit of the ApoE story, and it all is inextricably intertwined. But really, we need efficient delivery. We need all members of the team working together, or else we're going to run into issues.
Yeah. And I love that quote that you had said from that. Was it a physician that had said that genes don't ruin your life? I really like that quote because it's very reassuring for patients, because I'm sure they're very scared when they get one of these, positive genetic markers and they Google it and they're like, oh my gosh, I have dementia. They go down like a rabbit hole for that. So I love that. But are there other genetic risk factors for Alzheimer's disease that clinicians should be aware of to be able to better educate their patients?
Yeah, Alzheimer's disease is very multifactorial. And so ApoE is a strong genetic risk factor. There are other really rare conditions that can result in accelerated Alzheimer's disease and very early on. There is something called the presenilin 1 gene. There is the APP gene, which is amyloid precursor protein. Those are really rare, really rare. So I wouldn't worry about those at all. There are certain diseases like Niemann-Pick C disease, which will result in like childhood Alzheimer's. And that's a problem with what I call the intracellular cholesterol relay. And when cholesterol is not getting transported efficiently and it's accumulating in the wrong places, then that leads to all sorts of neurotoxicity. These are really rare conditions. But there are a host of genes that they have recently identified that are associated with Alzheimer's disease, but none is really like widely tested. There are lysosomal genes such as BIN1 and PICOM, which lysosome is kind of like the garbage disposal of the cell. And if you're not taking out the trash, well, messes are going to accumulate and there's going to be resultant toxicities. So there's different things that are associated with Alzheimer's disease, but none of them has quite as strong of an effect, or we don't know as much, I guess, about it as we do the ApoE gene. So I wouldn't really worry about going and getting your genome sequenced. But what I would concern myself with is maintaining proper glucose homeostasis across the lifespan, and then addressing all the other things that are part of our framework for not having heart disease as well. And that in general, I think, is the best use of our time, rather than going down the rabbit hole and seeing if we have an allele in the ApoC2 gene.
Yeah, no, I agree with you. Is it recommended for patients to be screened with an ApoE gene or not really?
I recommend it. I mean, and it used to be people would say, like, I don't want to know this. I don't want to know this. Well, it's not deterministic, as we know. It just tells you, hey, maybe I have less margin for error. And I think that there are some nuances we can have. And as precision medicine is getting better, we're going to have an individualized approach to not only cardiovascular disease, but also neurodegeneration. And they do go hand in hand. So I think, you should get it. It's a one-time thing. And there's some interesting factors, especially in the lipid realm, that you can take note of if you have a copy of ApoE4. For instance, ApoE4 carriers tend to be hyperabsorbers of cholesterol. And we kind of talked about that in the past. And there's this balance between synthesis and absorption. But if you know you're a hyperabsorber, then that is interesting, especially if there is a reason to consider some sort of lipid-lowering therapy. There are some nuances we can operate with if we know that. And so anyway, so there's things we should know. And like anything, right? If you have plaque in your coronaries, not knowing doesn't make it go away, right? And so all of these things, ignorance is not always bliss, especially when you can be proactive about it. If there was nothing we could do proactively, then yeah, I wouldn't want to know. But since there's so many things we can do, yeah, I want to know. I want to get the data, and then I want to go crush it at life.
Yeah. Okay. So we've gone high level with genes. Now let's bring it back to actually in clinic, what a PA could be doing with their patients. So are there any biomarkers or other labs that you would suggest for patients who maybe their parents have dementia or Alzheimer's, or just they're concerned about, their cognitive function in the future?
Yeah. And so I always prioritize parameters of glucose metabolism. And so you get your regular CMP, you probably are getting a HbA1c on people. Fasting insulin, or if you understand a C-peptide, which is co-secreted with insulin. But fasting insulin is a great, great test. Just because there are people who have normal blood sugars, normal fasting glucose, normal A1C, but their fasting insulin's elevated. Well, we know hyperinsulinemia is associated with an over twofold increase of Alzheimer's disease. And hey, insulin resistance, prediabetes, diabetes, they're all on the same continuum. And so identifying insulin resistance in its infancy and then abrogating it appropriately, particularly with all the lifestyle interventions we have, is super important. And then the association of coronary disease with dementia, that's pretty strong. And so doing the things that we already recommend as far as, getting a coronary artery calcium score when you're at a certain age. With our lipid panels, I think that it's always reasonable to order an ApoB in addition to your basic lipid panel, because particles dictate risk. And just the mass of cholesterol that you're getting on a basic blood panel, that's not going to capture the full picture of your lipid neighborhood. And then the Lp(a). I mean, Lp(a) isn't directly associated with Alzheimer's disease, but Lp(a) can be the felon of the lipid neighborhood, and you could get broken into. And we know that having established coronary disease is associated with dementia. So a lot of these things that we're already doing for identifying cardiovascular disease before it becomes problematic and getting ahead of the game there, shifting the paradigm from reactionary preventive, are going to be what we're doing also from the dementia standpoint. Now, specifically for dementia, though. And so we talked about ApoE genotype. I think getting your ApoE genotype is a good idea. Now, what's interesting is there is decreased cholesterol synthesis in people with Alzheimer's disease that I mentioned. And usually what we're getting on a plasma measurement does not correlate very well with what is going on with lipids in the central nervous system. But there is one biomarker that is pretty intriguing. And that is a biomarker called desmosterol. And so desmosterol is the penultimate precursor of cholesterol in what's called the block pathway of cholesterol synthesis, because none of these things can be easy, right? But desmosterol levels below the brain actually correlate quite well with desmosterol in the brain. And people with low desmosterol levels in both the Helsinki businessman study and another Japanese cohort, people with those low desmosterol levels tend to go on to develop Alzheimer's disease. If you have low desmosterol levels, this could actually give us some insight into what maybe not to use or what to use instead when it comes to a discussion of lipid-lowering therapies. Because for lipid-lowering therapy, we know what decreases cholesterol synthesis. Well, a statin does. Statins do a lot of good things. But if we're already low there, do we want to further suppress cholesterol synthesis? It's something that's in the theoretical realm, but something to consider. And then, if your desmosterol levels are high and there's a reason to consider lipid-lowering therapy, well, that gives us insight there on the other hand. And so desmosterol is an interesting biomarker. And so that's in the theoretical realm, but that's something to consider if you're really getting into the weeds as far as lipids. And then people with ApoE4, for instance, they tend to have a hard time actually transporting DHA, which is one of your omega-3s, into the brain. Omega-3 index is something that's readily actionable from a lifestyle style perspective, and low omega-3 index is associated with cardiovascular disease. And we know that DHA in particular is super important when it comes to proper brain function across the lifespan. So that's something to consider. There are other things like homocysteine levels that are higher associated with dementia and whatnot. And you could go down the rabbit hole forever and ever and ever. However, really those home security system pillars, as far as normal blood sugar, normal blood pressure, keep inflammation low, and don't do drugs. I mean, those are really the keys across the lifespan. And then doing our normal cardiovascular risk stratification. There are a few new biomarkers that have been correlated quite well with certain PET scans. And so there's something called p-tau217. There's an amyloid beta 42/40 ratio. There's some more non-specific markers. One's called glial fibrillary acidic protein, GFAP, and then there's another one, NFL, not the football league, but neurofilament light. And so those are some non-specific markers of neuroinflammation. I think those are going to gain more prominence. And then as we get a better understanding of what helps those markers, I think it's going to give us even more precision and more nuance when it comes to addressing these things. And if we can identify these things before they become problematic, then everybody wins.
Okay, you mentioned statins, and so I want to go there with that therapeutic intervention. And it's kind of debated when it comes to dementia risk. Some people say it's protective, some say it's harmful. So I'm curious as to what the evidence shows. And then how can you have this shared decision making with patients if you're about to start them on a statin or not?
What I'll say is at the population level, there is no increased incidence of dementia, right? And so now is it helpful for dementia? There's a few studies that actually seem to have less incidence of dementia. It likely depends on the person, okay? And so ApoE4 carriers tend to get a little less out of the statin at a population level anyway, just because they tend to be hyperabsorbers. And your body is always having this seesaw effect. If you absorb more cholesterol, you're going to synthesize less cholesterol. If you synthesize more cholesterol, you're going to have less absorption. And so that's why if there is a consideration for lipid-lowering therapy, let's say, somebody gets a CAC score and it's elevated or somebody has had a clinical event, hopefully not. But, if there's a consideration for somebody to be on lipid-lowering therapy, I'm a big fan of combination therapy anyway, and the only lipid-lowering therapy that we have right now that crosses the blood-brain barrier is the statin. And at one time, it was thought that the lipophilic statins, like atorvastatin, simvastatin, were the only ones that were crossing the blood-brain barrier. But all statins actually do cross the blood-brain barrier. And so, if cholesterol synthesis in the brain is important, which it is, and we could identify somebody who was oversynthesizing cholesterol, well, we would probably want to up the ante on the statin dose there. Conversely, if somebody has low markers of cholesterol synthesis, well, maybe we would want to throttle back and maybe we would want to consider either other lipid-lowering therapies or combination therapy. And I'm a big fan of always using combination therapy anyway, if there's a reason to, just because you're able to minimize some of the dose-dependent side effects of the statin anyway. And we know that, high-intensity statin outside of acute coronary syndrome, there isn't quite as big a place for that as we once thought, just because we have other tools in our toolbox, just because you're going to increase some tolerability issues. The risk of new onset diabetes does occur at higher intensities of statins, but the most bang for your buck you're getting with ApoB reduction is that initial dose of your statin anyway. And then you can add on other therapies and hopefully we can live in a safer lipid neighborhood without impairing quality of life and impairing other elements of our home security system in the process. And so really, statins are a great tool. They do a lot of good things. And I think that as we identify ways to have a more precision approach to neurodegeneration, that will help us even better utilize our statins and our other non-statin lipid-lowering therapies, depending on the context, for neurodegenerative disease as well.
Super helpful. Okay, let's bring it to nutrition because this podcast is all about nutrition. So I'm curious if a patient were to come to you and say, hey, Josh, like what can I eat to improve my cognitive function, to prevent dementia? Like what are some key areas that clinicians can educate their patients on?
Yeah. And so if I'm seeing any signs of insulin resistance on your blood work, the first question I ask is, okay, well, are you exercising? And because exercise is the most potent tool that we have to mitigate neurodegeneration. And there are multiple effects that we've seen. And one of the things that, if anybody has seen a Rhonda Patrick podcast, she talks about brain derived neurotrophic factor, or BDNF, a lot. And BDNF is elicited in response to exercise. And that is important for neuronal function and regeneration. Okay, and that's awesome, and so exercise is super, super paramount importance, but also exercise is incredibly important for glucose disposal, and we know the importance of utilizing glucose efficiently across the lifespan. Now, if the person is exercising, or maybe they're not in a position to, you meet people where they're at, or they're just not going to do it, well, then let's have a more detailed discussion. What are we eating? I think people who have a APOE APOE4 genotype, I should say, they're probably going to have some more outsized benefit from getting more omega-3 type meals in their diet. There's some observational studies that show a Mediterranean type intervention for APOE4 homozygotes is quite effective. But these are all these things. There's a lot of variables going into that. And so, I think whatever you're doing dietarily, prioritize protein, eat real food. And if we're seeing signs of insulin resistance, we need to go back to the drawing board on whatever you're doing dietarily and go from there.
Yeah. I actually did an episode with a prolific registered dietitian in the brain space on the mind diet. And I really, really loved that diet intervention and that episode. So if you guys want to learn more about one of the dietary options for brain health and cognitive function, go check out episode 80. It's called The Mind Diet, What to Eat for Brain Health after this episode, if you want to dig more into the nuances of brain-specific healthy foods that would help with cognition. Okay, Josh, my final question, because you are deep in the trenches of research. I'm just curious. I would love to hear if there's any promising interventions on the horizons that maybe we should be aware of or keep our eye out on.
Yeah, so some of these interventions I probably can't talk about, or else I'll get fired for my day job. But really, I think sometimes the most important prescription we can give people is hope. And I'm very hopeful. And I think, as we've discussed, and people are getting just a little bit of this. I mean, it's so incredibly complicated. I've tried to distill it just a little bit, but as you can see, this topic is wild. But there are things on the horizon, and I think it's going to be more of a metabolic and lipid-centric cocktail that's individualized for people who might be in those early stages of mild cognitive impairment, or maybe, hopefully, we can identify that even before cognitive impairment, and then we can intervene appropriately. And I don't believe that just blitzing everybody with something that targets amyloid beta, for instance, is going to be the be-all, end-all, just because, as we talked about, all these things are very complicated. There are many factors that contribute to dementia. And so it would be, I think, too simple to just say, hey, here's one protein. We see amyloid beta aggregates. We see hyperphosphorylated tau. If we can just take away those things, then we're going to be fine. I think that we need to intervene sooner. And I think that some of the things that we do see, like amyloid beta aggregates, like hyperphosphorylated tau, are downstream consequences of inappropriate substrate utilization and the lipid disturbances that ensue, rather than being the probably most optimal targets for people, especially if we want to get ahead of the game. And so there have been some preclinical studies that have shown some promise in neuroprotection for things like GLP-1 receptor agonists, and like semaglutide, things like that. And that doesn't really surprise me, because we know that optimizing glucose utilization across the lifespan is so important, and those medications help you do that. And whether you need a catalyst to do it, or whether you can just do that without a medication catalyst, I think that's going to be super helpful no matter where you're at in the process. And then there are some interesting things as far as lipids go that I can't probably speak to as much as I would like. But you can always hit me up offline, because these are some of the best discussions ever as far as some of the lipid-related targets that we're having a better understanding of, that I think in the right person at the right time, we could utilize to abrogate some of the tendency towards neurodegeneration. It's exciting. And so I think that people should be excited. And, there's a big difference between living and existing. And that's why I'm so passionate about not only mitigating cardiovascular disease, but also seeing if we can stem the tide of neurodegeneration. And so hopefully for as long as God keeps us around, we can be crushing it together. And that's an exciting thing to me, and it should infuse us with hope.
What a great message to end with. And it is really, really exciting. And honestly, your passion is contagious. I love having you on to talk about all things cardiovascular health, but now obviously with Alzheimer's prevention. This was such a helpful conversation. So Josh, as always, I really appreciate unpacking your brain on these really complex topics. So thanks for making it fun. Now, if people want to connect with you, learn more about you, or find your book, where should we direct them to?
Yeah, so Amazon is where my book is. That's the home security system in the lipid neighborhood. And hopefully in time for Christmas, there will be a remixed second edition for the clinician and anyone on a mission for more lipid tuition. And that's done. It's just in the final stages of being formatted. So if you just couldn't get enough from the first version and you wanted to have a deep dive into the community pool of complex physiology, and there's an endocrine thermostat section with topics such as postmenopausal HRT and the effect of thyroid hormones and adrenal hormones on your lipid neighborhood, things of that nature. There's a section on lean mass hyperresponders and ketogenic diet-induced hypercholesterolemia and some of the mechanisms I think are going on there. So there's a bunch more stuff, and there's more funny stories from my life too. If you just are like, I'm sick of all these lipids, but you just want to, read like how I met my wife and some other funny stuff, then hey, that's in there for you too. And so that'll be coming out hopefully by just in time for Christmas, because man, the gift of lipids just keeps on giving. So there's that, but you can find
everybody's list.
Yeah, right. I'm sure. I mean, what more could you want? And so anyway, but no, I'm on Insta. I'm terrible at Insta, but you can find me there. I am on X, formerly known as Twitter, and LinkedIn. There's a lot of people that find me on LinkedIn. And yeah, a lot of people end up listening to these things and they reach out to me personally. And as long as you're not creepy, I'm totally fine with that. Just send me a private message and we can hopefully have some fun together.
Thank you for all the incredible resources you provide the community for more knowledge on brain health and cardiovascular disease risk prevention. Josh, thanks so much for being here today.
Thanks for having me.
If today's episode resonated with you, I would love to hear about it. Shoot me a message on Instagram at Exam Room Nutrition and tell me your biggest takeaways. I hope you guys have a great day, and thanks for carving out some time for nutrition today. I'll see you next week.